Hello, I'm Seth Martin. I'm a Poland cardiovascular fellow from Johns Hopkins University. I'm the associate editor of the Cardiosource Dyslipidemia community, and I have the distinct privilege to be here to discuss the new risk assessment guidelines, which were jointly released by the ACC, AHA. I'm here with Dr. Peter Wilson. Thank you for joining us, Dr. Wilson.
Glad to be here, Seth. It's fun to be at the heart meetings. It's always exciting, and with the new guidelines rolling out, we're starting to get some feeling for the uptake, I guess.
Yeah, there's a lot of buzz. Everyone's talking around the halls here at AHA of the new guidelines. What's the uptake been like so far?
So first of all, what's different in the guidelines from the past? The first is this is a pooled equation. It's no longer just Framingham. It includes other NHLBI databases such as Cardia, ERIC, CHS, and there was efforts made to calibrate. Now, we'll have to talk about that for a second, to calibrate it into other American cohorts to test how well it works.
And we'll get to that issue, I guess, of calibration in just a moment. It's a virtue of the new equation that it's considering these other underrepresented groups in the calculation. That's something that's new, isn't it?
So we would have loved to have had virtually all major ethnic and racial groups, but where the data are, or have been, and that's what you need, prospective data with follow-up, is been largely in African Americans and in whites. The whites is all we had before.
Absolutely. And tell us a little about calibration. What was, in terms of developing this new risk calculator, how did that factor into the decision making?
So when you develop a calculation, you know it works in the cohort where you developed it. The point is, can you so-called export it to another group? For instance, Framingham, we had a major effort after the 1998 equations to calibrate it into other cohorts around the United States. And there's always some element of a non-fit. It reminds you of high school science. The slopes can be very similar, but the intercepts are different. You know what I mean? With those science experiments. Right, yeah. That's the concept of calibration, is do you move the intercepts up and down? And we've done some element of that, and it was not quite as good as we'd like. And more recently, there have been other developments, even at this meeting.
And tell us a little about those and what we could do to address those developments, if there is any difference in calibration from one population to another. I guess the inputs for the model are still right. It's just we got to get them calibrated.
That's a second issue. So let's first deal with, if we use the same inputs, for instance, Paul Ridker and Nancy Cook at the Brigham have 3 very large cohorts, more contemporaneous, more recent data, and they're finding that there's not as good a calibration as we'd like to think. So that is raised with this uptake, so to speak, is how well is this going to translate into the patient I'm going to see in the next few years? It was just developed, and I have patients coming in next month. Should I use this equation, or should we do something to it, so to speak? And one of the possibilities for sure is to reinvestigate and to recalibrate or harmonize the calibrations. How would that work? Right. That's not, first of all, been decided, but that would work by getting all the teams together, all the databases, and working rather efficiently, we would hope, because there's a lot of interest in this, coming up with something that would do the best fit. One of the things for sure is cardiovascular rates have been going down. Anybody who is recruiting for trials knows they've been going down. So having those risk factors back in the 1970s and 80s is different from having them in the year 2013, 2014, and 15 when we're going to want to use the calculators.
Right. And so what we want to do is get more patients that may be more relevant to the current era and really compare and find out how we can calibrate in that population. Is that?
That might be one of the ways, but the other is to take the elements of when the data were obtained and develop a new variable that would calibrate. And the calendar year is one of those new variables. And so it would help sort of dovetail the whole concept of where we have been and where we are going. And it would that would for sure be one of the early steps, is trying to reconcile these differences. And some of the differences are across time. It's not that something was done right or wrong. It's just that things are changing, and they're changing rather rapidly because our patients are taking medicines, and now we have potent medicines, and we have a pretty good buy-in for most of our guidelines.
So I think it sounds like there's a healthy debate and collaborations going on right now to make sure that we get this right, because ultimately we want to get it right for the patients that we're treating, as you said, in the clinic, the ones that are at the bedside. Right. And so tell us, how quickly do we think we can get this right?
I don't think we know. We don't have a consensus on exactly what ought to happen next. This is the sort of thing Ralph D'Agostino and I and others, and Paul and Nancy Cook, all of us have done this sort of effort before, but we sort of are now seeing how this might play out. I did want to mention one other thing that the clinicians will be asking about that is generally not there. One of them is we don't have coronary artery calcium screening. We do not have C-reactive protein in these algorithms, and we do not have statin treatment effects. That's one of the challenges of the future. I think with the short-term harmonization, calibration, that will not lead to those new factors coming in. But that's future work.
Right. Well, we have to thank you so much for joining us here today on the Cardiosource Dyslipidemia community. We thank you for all the work that you're doing and collaborating with everyone to make sure that we get this perfectly calibrated, or as best as we can do. So thank you again, and thanks to everyone for joining us.
Thanks for having me.